So this is a learning objective for today's lecture. Classify streptococcus species, describe the morphology, pathogenesis, toxin, virulence factors, and details of the streptococcus pyogenes, the infections caused by streptococcus pyogenes, define rheumatic fever, and so on. So rheumatic fever basically is post-infectious disease. So post-infectious disease means that there is a bacteria known as streptococcus pyogenes, and it generally affects the uh, throat or the upper respiratory tract, causing sore throat, and patient recovers from that particular infection. But after a certain period of time, because of the immune response, you have the patient who is presenting with what is known as rheumatic fever. So we will be going to it in short while, but let us start with the bacteria which causes rheumatic fever, which is nothing but the streptococcus pyogenes, or group A streptococcus as it is known as. As we know, it is streptococcus. Coccus means cocci. So the bacteria is gram-positive cocci. So all streptococci will be gram-positive streptococci, which may be in different shapes and arrangement, which can you see now. So left one, which you see is group A streptococcus, which has the gram stain which has been prepared from the blood culture bottle. So it is a liquid medium where you can see long chains of cocci which are seen. You can easily say that it is a streptococci, because you need to differentiate it from staphylococcus, which is there in a grape-like cluster, whereas the streptococcus is having short chains or very long chains, depending on which medium and the bacteria or species it is. On the right hand side, you see it is the arrangement which is known as diplococcus. So all the bacteria which are say here in the right side panel are is in pair, right? So this pair kind of arrangement is seen with the streptococci of certain species. So you, based on the gram stain also, sometimes you can make a presumptive diagnosis whether it is a particular streptococcus which is seen in long chains or short chains, or the streptococcus which is seen in pairs. The right hand side picture is of the streptococcus pneumoniae. On the left hand side, you have the picture of the group A streptococcus. So streptococci are the spherical or ovoid bacteria which are arranged in chains, and they divide in parallel. So laying perpendicular to the long axis of the chain. So this is the long axis of the chain, so perpendicular to that, so they are dividing. So that is why they are able to make a long chain. Diplococcal rod-like forms are also sometimes seen, which you can see here in this particular photograph on the left. Lengths of the chains vary widely and are conditioned by the environmental factor. As I said, in the liquid medium, you will have a longer chains. This gram positivity is, however, in some species is affected by whether the bacteria was taken from the live culture or a dead bacteria. So gram positive, as the culture ages and the bacteria die, they lose their gram positivity and can appear as gram negative in older cultures. So that you need to keep in your mind. So there are various ways of classification of these streptococci. One is based on the culture characteristics or the colony morphology and the hemolytic reaction. We will be coming to it. Then second is the serological specificity of the cell wall group. That means there is some specific antigen which are known as Lancefield antigen, because of the name of the Rebecca Lancefield. She was the one who first discovered this antigenic substance in the streptococci, and the grouping is there. So that is having a specific antibody for specific antigen. So serological specificity is there. So that can be done. Third is biochemical reactions, as we do it for the other bacteria. So in the on the bench side, you can do with all the resistance to the physical and chemical characters. Ecological feature, where they are found, and molecular genetics, which has largely now replaced all different types of classification. So we are left the main classification or the taxonomic uh, classification is mainly based on the molecular characteristics of a bacteria. So we will be discussing mainly two classification here. One is the hemolytic or the cultural one, and the other one is the Lancefield. So this is a picture which shows you two different kinds of plates. Left side, if you see, you have the colonies which are having the greenish hue around the colony, and if you compare it on the right side, there is a colony which is having a clearance around it. So it is, if you see the blood agar plates, so these are the blood agar plates. So blood is being digested completely here on the right hand panel. So erythrocytes are completely disrupted with clearing of blood around the blood bacterial growth. So this is nothing but it is known as the beta hemolytic colonies. On the left hand side, the digestion is not complete. So lysis of RBCs is not complete, and the hemoglobin which is there is reduced, so it is giving you the green pigment. So greenish hue is there, that is known as alpha hemolysis. So greenish hue, partial digestion is alpha hemolysis, complete digestion and clearing of zone is the beta hemolysis. And if there is none of the hemolysis, so partial or complete, there is no hemolysis, that is also acronymed as gamma hemolysis. The other way to classify here is the Lancefield grouping. So it is based on the carbohydrate antigen which is contained in the cell wall of many streptococci. So different specific serogroups are named through alphabet. So serogroup A, serogroup B, serogroup C, and so on. So when the molecular nature of these antigens was looked into, they are nothing but the group specific carbohydrate which has a amino sugar which is attached to it, and the difference between the amino sugar and the functional group to the carbohydrate gives the particular antigen specificity. So group A to H and K to U are available. So this is generally the MCQ which comes up, may not be asked in the MBBS exam, but the MCQs for the PG exam. So which particular group has what kind of carbohydrate antigen which is there. So group A, you have the rhamnose and acetyl glucosamine, group B rhamnose glucosamine, and so on. So this is based on this antigen. So each particular antigen has a specific antibody. So specific antibody is nothing but the antisera which is being used to identify particular group of bacteria. So if you see, so based on the Lancefield grouping, you have the classification of the bacteria, and there is another classification which is nothing but the beta hemolytic and the alpha hemolytic. Alpha hemolytic are being mainly most of the alpha hemolytic streptococci are grouped together into the large group which is known as Virulence streptococci. So we will be reading about the Virulence streptococci later, but just to be for the today's class, it is the beta hemolytic streptococci. So there are three major group of beta hemolytic streptococci. One is group A streptococcus, as it is short form is the GAS or gas. So the main the species is the group A streptococci. The scientific name is the Streptococcus pyogenes. Group B streptococcus, the biological name is the Streptococcus agalactiae. Group other species which are there is the Streptococcus dysagalactae and equisimilis, subspecies equisimilis, which is also beta hemolytic. So this we will be coming at the last point of our today's lecture. We will be discussing about it. So the normal habitat for group A Streptococcus is exclusively human throat and skin. So they are not found in the animals or the other parts or other species. as a host. So humans are the only host. So throat and the skin of the humans are the normal habitat of the Streptococcus pyogenes. So what does that mean is there is a carriage of group A Streptococcus. Similarly, group B Streptococcus carriage is seen in the genital tract or lower gastrointestinal tract, right? So there are ways to differentiate group A and B. So the colony characteristics is the one of them. Then there are certain biochemical tests which you can put in and you can look into the group B or group A differentiating in the two. So group B streptococcus you have already been discussed in the meningitis or the portion of the STI, but we will be restricting today on mainly the group A streptococcus, which is causative agent for the rheumatic fever, and the acute phase it causes many other presentation which we'll be discussing shortly. Other group which is the non-beta hemolytic or the alpha hemolytic group is there, which is largely named as Virulence streptococci. We will be discussing that in detail in our next lecture on endocarditis. So when we come to the epidemiology of the group A streptococcus, as I told you that the main habitat or the exclusive habitat is the human respiratory tract. So it is there on the in the throat or sometimes on the skin of the humans. So it is the carriage of upper respiratory tract. It is around 3 to 5% of the adults carry group A streptococcus, healthy adults, and healthy children up to 10% can have the group A streptococcus without any problem, without any infection, without any disease. Transmission is through droplet spread, that is the through the respiratory droplets. And once the transmission is, so the other person susceptible host, if acquired this particular bacteria through the droplet infection, it may become asymptomatic. It may have a pharyngitis which can extend to tonsillitis and so on. And after acquiring it, they may continue to carry it, which are known as the carriers. And last is the invasive group A streptococcus. Yes, we are going to discuss soon. There are various risk factors for acquiring the group A streptococcus infection. The extreme of ages, so mainly here the older age group, more than 65 years old, recent varicella zoster infection, because varicella zoster infection means immune suppression which is happening. HIV positive individuals, again immune suppression. Diabetes, again it is a part of immune suppression. Cancer, again immune suppression. Injecting drug use, so it can be because of immune suppression, because of the comorbidities of HIV and others, or it could be the skin. When you are injecting and you are not injecting aseptically, the group A streptococcus and skin can get into your system. And then, of course, high dose steroid, again, because of the immune system, it can lead to the increased predisposition towards group A streptococcus. But this risk factor does not mean that only these groups are going to be affected. Without these risk factor, there is also the children mainly which can get the infection. So coming to how does this streptococcus cause a disease? So when we talk of a cause of disease, there are certain antigens or the protein components or the carbohydrate components which are being, or the enzymes which are being secreted or present on the surface of the bacteria, which lead to the disease process. So on the surface of this bacteria, which is also known as the somatic constituents, we have the capsule which is having the hyaluronic acid, which is having specific receptors on the permissive cells, leading to the internalization and then causing disease. Then we have a major virulence factor, which is nothing but the M protein. Then serum opacity factor, lipotecoic acid, which is present across all the gram-positive bacteria, fibronectin binding protein. So these are the structural elements or the somatic constituents of this particular group A streptococcus, which can lead to the pathogenesis and the disease causation. Apart from it, there are various extracellular products or the enzymes or the chemicals or the proteins which are being secreted, which can lead to the enhancement of the disease or symptomatology. So among these, streptolysin O and S, but there we will be coming to it. So streptolysin O and S, DNases A to D, then streptokinase, then certain pyrogenic exotoxins are part of the extracellular products along with the streptococcal superantigens. So the important one we are going to discuss in subsequent slides. So coming to the somatic constituents, hyaluronic acid capsule, which is nothing but it is the uh, capsule has a specific receptor on the cell, which is nothing but the CD44 carrying cells, which are permissive to it. So they can bind to it, and then this will lead to the breakage of the intracellular junction. So that is why despite causing disease, this particular bacteria can remain extracellular. And of course, it helps in phagocytosis, so it helps in the process of what is known as camouflage. So that is the other mechanism for hyaluronic acid to evade the human immune response and enhance the virulence. Second is the M protein. We will be coming to it in more detail because it is one of the very major virulence factor. It helps in the evasion of phagocytosis and inhibits binding of the antibody to the opsonin C3b. So opsonin, so it is mainly a C3b complement inhibitor. That is the major mechanism through which it acts. And of course, then we have the other factors which we have seen. So what this picture on the right is showing is the M protein, which is embedded into the cell membrane and protrude through the capsule out to the outside, and they have the certain receptors which will be responsible for the uh, virulence of the blood the diagnosis. In terms of pharyngitis, which may cause presentation is known as the impetigo, but there can be other severe manifestation in terms of erysipelas, cellulitis, necrotizing fasciitis, and pyomyositis. Then we have streptococcal toxic shock syndrome and scarlet fever. As I told you that because of the cross-reacting antibodies against the specific M proteins, after the infection has passed off, the patient may develop the clinical entities known as rheumatic fever and glomerulonephritis. Apart from these localized infection or immune-mediated actions, there are other infections through which it can present, like bacteremia or presence of the bacteria in blood along with the symptoms, and then meningitis, osteomyelitis, purpurine sepsis, and septic arthritis. So this is just to show you how the group A pharyngitis look like. It can be highly inflamed on the left panel, which you can see around, and it could be inflammation along with the petechial spots or the red spots, which can be seen on the hard palate and the tonsillar surface, and then the posterior pharyngeal wall. The other presentation is impetigo, which can lead to further deep abscesses and the involvement of the lymph nodes, and then the diagnosis is generally by the aspiration of these nodes and then further processing into the laboratory. This is erysipelas, where you have the nothing but it is a cellulitis of the skin, and there is a malar kind of rash-like appearance which can be seen around. It is nothing but there is a severe infection. So it is like a tissue digesting bacteria, it is sometimes known as, along with there are many others. Then it can be a cellulitis. Cellulitis means the inflammation of the soft tissue along with the involvement of the joint, the arthritis. So that can be the another presentation of group A streptococcus. This is the sloughing of the skin, which is seen. So if the patient may have a bacteremia, may develop certain boils like the toxic shock syndrome, if you have seen systemic manifestations, or then there is a sloughing off of the skin. So discoloration of the skins of the hands can occur following this particular group A infection. The lines which you see around, which is these dark lines which are there, these are nothing but the Bastia lines. Again, these are seen in the patients with the scarlet fever, which is nothing but the due to the infection of the group A streptococcus. Another presentation which is there is the erythema marginatum. So erythema marginatum means there is a redness and then slowly it will spread out, and there is a sharp area which is having severe erythema, sometimes erythema which can be sometimes raised also. So this is like in an Indian child, you see the picture like this, and this is in the white child. So this is the erythema marginatum, which is the again presentation of the rash which is seen with the rheumatic fever. Purpura fulminans, as with the various other types of bacteria, notably the meningococcemia, this kind of picture can occur with the group A streptococcus or streptococcus vagins after septicemia or the bacteremia. So it is nothing but large vertical rash is there. You just poke the skin and make a impression smear of it and look under the gram stain, and it will give you the diagnosis. So easy to diagnose, but very fatal for the person who is having this. Then on the right hand panel, it is showing you the consolidation here, which you see around on the left side of the patient. So again, this is a pneumonia which is being seen with this particular patient. So Streptococcus pyogenes can also present with the pneumonia. Another interesting picture just to show you the BU lines or on the toenails. So these are the horizontal lines which you see around. This is again because of the severe protracted group A streptococcus. So these are the important presentations which you will see around with group A streptococcus along with the rheumatic fever. Post these presentation, the patient may develop with the rheumatic fever. So many of the patients who are coming after post streptococcal infection may present with these features. Uh, so with rheumatic fever, they may have a history of these features, and many a times it is the patient may be asymptomatic for sore throat. So if you are suspecting basically the rheumatic fever in a patient, the patient may or may not give history of sore throat. So it's not imperative that all patients with rheumatic fever will have the sore throat. So asymptomatic infection can also lead to rheumatic fever. Okay, now let us go to the post-streptococcal sequelae. So post-streptococcal infection, generally this sequelae is manifested after 1 to 5 weeks, depending on which sequelae we are talking of. Nephritis, generally the mean days is 7 days, and for rheumatic fever it may come up to 2 to 3 weeks after the acute post-streptococcal infection. So this is not attributable to mainly that the bacteria has spread across into the kidneys or into the heart. It is basically an immune phenomena. Type 2 and type 3 hypersensitivity, mainly immune complex mediated for the glomerulonephritis part, and type 2 for the rheumatic fever. So nephritis is more commonly preceded by the skin infections, whereas the rheumatic fever is more commonly preceded by the respiratory tract infections. So most serious sequelae of Streptococcus pyogenes is the rheumatic fever. And why it is said so? Because it damages the heart, muscle and valve permanently. So once damaged, they can't be repaired. You have to just replace them with the artificial valves. If the deformity becomes incompatible to the life. So cell membrane antigens of the specific group A Streptococcus strains cross-react with the human heart tissue antigens, which we have already discussed, mainly the M protein, which we have talked of. Sera from the patient with rheumatic fever contains antibody to these antigens. That is why we can do the estimation to diagnose rheumatic fever. It will be latent period means that the acute phase of respiratory infection has passed and the patient is now presenting with the manifestation of the rheumatic fever is generally 2 to 3 weeks, and mainly it is 5 to 6 weeks. So dry throat infection may be asymptomatic, and 0.3 to 3% of the streptococcal respiratory tract infection can develop rheumatic fever if untreated. So various signs and symptoms, fever, as rheumatic fever is suggesting, so fever, malaise or general weakness will be there. Apart from it, there will be migratory non-suppurative polyarthritis. So that is the another hallmark feature along with the carditis. So as we have discussed earlier, all three layers of the heart, endocardium, myocardium and pericardium are affected. They become inflamed because of the cross-reacting antibody phenomena, and it will lead to the thickening and deformed valves, heart valves, because of the small perivascular granulomas and finally leading to the scarring of the tissue. So scarring means the permanent damage. Then another interesting feature is what is known as Sydenham's chorea. Sydenham chorea is nothing but it's involuntary, uncoordinated movements associated with muscle weakness. That means there is a movement, unexplained kind of movement of the hands or the muscles, eye muscles, or any other skeletal legs can occur. So the patient is very, very characteristic with this particular presentation, which is known as the Sydenham chorea. Another important feature which can be there is the PANDAS, as it is acronymed as. It is the post-streptococcal autoimmune neuropsychiatric disorder associated with streptococcus. So that can be also seen in with the uh, some of the patients with the rheumatic fever. So how to diagnose a patient of a rheumatic fever or suspect a patient of the rheumatic fever? So there is a Jones criteria which are there, major criteria and minor criteria. So diagnosis required at least two major criteria of all the five criteria which have been defined under the major criteria, or it could be one major and two minor criteria. Okay. So major criteria include carditis, as we have discussed, polyarthritis, chorea, erythema marginatum, which I showed you, and along with it is this subcutaneous nodule. It is nothing but some unexplained painless swelling which is there beneath the skin, which is there. So subcutaneous nodules can be there. So they all are part of the major criteria. So if two of them are present, that means the patient is having acute rheumatic fever, or if one of this and another one, two from the minor criteria, that means fever or arthralgia or lab finding in terms of acute phase reactants. Acute phase reactant example is the C reactive protein or the ESR, erythrocyte sedimentation rate, along with the prolonged PR interval. PR interval is nothing but the interval which you see on the electrocardiogram or ECG. So they have the P wave QRS complex and then followed by T wave. So there is a difference between or lag between the P wave and the initiation of the R wave. So this will be taught to you more about it in the medicine, but just to remember here, prolonged PR interval. Then there could be certain supporting evidence in terms of positive throat culture, rapid gas antigen, or rising antibody titer. But here the important thing to remember is all rheumatic fever cases may not yield the positive throat culture because it is a after infection disease. So you may not even have any evidence of the prior streptococcal infection, and the patient may end up with all the criteria of the uh, rheumatic fever. So again, this is a diagram to just show you that above picture, if you see, these are the normal valves, very good surface, no rugosity here, very much approximated and closed. This is the affected wall where the scarring has happened. So there is a incompetence in the damage is there. So open drainage. So this will lead to the regurgitation of the blood from the ventricle to the atrium. So this is the actual picture of the wall which is damaged. So there is a leakage of blood which can happen, which is being heard clinically as what is known as murmur. So that can be there. Okay, now coming to the other respiratory disease, because when you are thinking of streptococcal sore throat, you have to think of other viral or bacterial infection which can present with simple things. So it can be viral infection or it can be the bacterial infection which can be there. So this is just to show you the hallmark presence of the pus pockets on the throat which may be seen in the grouping streptococcus. But just presence of inflammation and even presence of pus does not mean the patient is having streptococcal infection and you start with the antibiotic. That should not happen. So then there are defined criteria for streptococcal toxic shock syndrome again, as we have seen with the um, rheumatic fever, you have the criteria for the uh, toxic option syndrome. Here, what is important is that you need to isolate the bacteria, isolate the group A streptococcus from the patient sample, which has to be there. Then along with it, you can have from the first is the from the sterile side, whether it's a blood, CSF, peritoneal fluid tissue, depending on the presentation, and then there is a set of clinical presentation which is there. Then there are again definitions which are there in for the streptococcal toxic shock syndrome, along with or without necrotizing fasciitis. We will skip that part of it. So lab diagnosis, as we do in microbiology, we start with the clinical presentation. Based on clinical presentation, you have the samples to be collected. For streptococcal infection, you need to have a throat swab. For pharyngitis or the respiratory infections, which we are suspecting, and for rheumatic fever also, you have to have the would like to see